Natacha, and most of you probably know Dr. Marty Stein, who I have been blessed to know since about July of 1992 when I came here for my residency training. And we've come a long ways together. Dr. Stein is actually our son's pediatrician. Dr. Stein is a world-renowned expert in behavioral pediatrics, and he has spoken in the past, and I'm going to ask him to make a few introductory comments based on his experience and knowledge and what he's seen today. And then we're going to open it up for questions to the whole panel. So first of all, here is a token of appreciation thanks to the Sulpizios.
Thank you, Tricia.
T-shirt.
Oh, wow, great. Thank you.
Go ahead.
Thanks. It's nice to see you here, and it's nice to see you all here again. I think this is the perhaps third or fourth time I've been to this conference. And just a few comments before we get to your questions, because I think that's what we want to spend this hour or two with, to be responsive to your questions. Sitting here this morning and listening, I was just struck on many levels how unique this conference is and how unique the study of Jacobson syndrome has become. You know, it's remarkable how you saw two aspects of studying your children. You know, one is kind of behavioral and cognitive, looking at their behaviors, looking at their thinking processes, which you heard in the first two talks, and the other is the biological aspect of Jacobson syndrome. And they're clearly linked, and the people involved, the four speakers this morning, are attempting to link those. That is, the behaviors and social adaptations of your children and the thought process of your children on the one hand, and how that relates to what the biological foundation is of Jacobson syndrome. And to the extent this is done with this disorder, there are only a few disorders that researchers are doing it to this extent. And I think it says a lot for the people committed to this, both parents, family members, as well as the researchers, and it says a lot potentially for the future. I mean, disorders like Fragile X syndrome, which is perhaps somewhat genetic, but primarily an alcohol exposure problem during pregnancy, it is also being done like this, where you have researchers on both sides, and there are a few others. But I think it's the kind of effort that will not only help children with Jacobson syndrome, but I suspect over the years the discoveries made will help children and adults with other neurocognitive, neurobehavioral kinds of genetic problems. At least that should be the hope. And one other thing I want to share with you is a personal anecdote that occurred to me about 30 years ago. I was a general pediatrician for many years. Certainly when Paul and I first met in '92, I was a general pediatrician rather than the situation I'm in now, which is in the area of developmental behavioral pediatrics. But in that capacity, I did see a lot of children with various physical and emotional disabilities. And I saw a lot of children with ADHD as well, and these were otherwise usually typically developing kids who had ADHD, and this is now 30 years ago. And I was sort of taught or not taught that you shouldn't think about ADHD in kids who have significant disabilities, particularly cognitive disabilities, children who are retarded to some extent, that you can't diagnose ADHD in those kids, and we don't think about that. Well, about 30 years ago, or 32 years ago, two nurses from North County brought me this, this Mexican child. I say Mexican, not Mexican-American. I mean, her parents were here without immigration papers. They were afraid to come to the hospital because of that, but they allowed the nurses to bring this child to me. She was 10 years old, and she had Down syndrome. She had trisomy 21 Down syndrome, and the nurses were sure she had ADHD. She had all the characteristics of significant hyperactivity, impulsivity, and inattention in the classroom. They felt she had some potential to learn, but the ADHD behaviors were inhibiting learning, inhibiting her from using her potential. So with the parents' permission, she brought them to me, and I had never seen a child with that level of disability with ADHD, but sure enough, she fit all the behavioral criteria that we use to diagnose ADHD, and I treated her with a very small dose of medication. It was methylphenidate, which is Ritalin or Concerta today, methylphenidate being the chemical, and a very small dose had a dramatic response in this 10-year-old with Down syndrome. She was less hyperactive, she was more attentive in the classroom, she was less impulsive, and she clearly started learning, and her behavior improved. Well, my eyes suddenly opened. My gosh, you know, we have to look at these behaviors that previously were thought to be limited to kids who are typically developing other than these behavior problems. And I think that relates to the children with Jacobson syndrome as well. As we heard this morning, a significant number of your children probably have ADHD, as many as a half we heard this morning, whereas the incidence in the typically developing population is about 6 to 8%. And there are many other behavioral conditions, I think, that are similar, like anxiety, and well, anxiety would be the primary one, and oppositional type behaviors. But I thought I'd share that with you because that was a 30-year historical experience to me that has impacted my practice of medicine in pediatrics tremendously, and the way I look at children with a variety of disabilities and give them every opportunity as other children to recognize if there is a disorder that can be responsive to either a medicine or a form of behavioral modification, that it's important to make that diagnosis and help families find treatment that will be useful. So, with that introduction, let's hear from you and questions for the panel from this morning.
I'm Emma Williams, and this is my daughter, LaJoy.
Let me, is that the cordless?
I'm going to see.
Okay, you're going to, you know, I can do that, and then, because the questions are going to go to you guys, so.
Okay, yeah.
And I didn't get a chance to introduce her last night. LaJoy is 36 years old. She was born in 1976. And at that time, they told me it was 6 cases only that they knew of, and they couldn't tell me what she'll do, what she wouldn't do. They would watch and study her, and she would tell them what she'll do and what she wouldn't do. And I raised her these 36 years not knowing anything besides she had 11q minus syndrome, and that was it. And it's turned out fine, but she had speech problems and other problems. The first 4 years was rough, real rough, in and out the hospital and different things that was going on. Today, it's my first time ever being at the conference, ever seeing anybody else besides her with the syndrome. And after 18 years of being at Oakland Children's Hospital and being studied, and after 18 years, it was over with. I guess she was on her own. And so now she's over at UC San Francisco, and the doctors there are seeing her. And her doctor is very much interested in the syndrome and things, but other than that, nobody knew anything. I didn't know anything. And I'm learning everything today after 36 years.
It's
So,
never too late.
never too late, never too late.
We're thrilled you could be here. Oh, sure.
Yeah, as you started to talk, it reminded me of the fact that all genetic syndromes that have behavioral and learning problems with children, including Jacobson syndrome, have a wide range of manifestations. So not everybody looks alike, obviously, and you kind of implied that as you said something about your child. In part, that's why they couldn't tell you, although not really. If there were only 6 patients, then they didn't know much. But that's a very important concept, and I think it's only in the last few years with the kind of biological research you heard that we're beginning to understand what the molecular biology and genetics of these differences are. And it's not only for behavior and learning, but structural problems like the kind of heart disease that Paul deals with. Tremendous variability, even though all the children have the 11q deletion. There's different degrees of it, and it depends what the mutation is. And so, even with a single condition, there is a wide variety of presentations.
All right, I'm going to get my exercise here. So, I'll come over there, but just be persistent, everybody. We've got 2 hours.
Okay, hi. I'm Stephanie Christensen. Our daughter Sydney is turning 6 tomorrow. And I think like a lot of 11q children, she's extremely social and at times overly social in that she'll do things like go up and hug strangers at Target because she just wants to say hi. And it's very cute at this age. She's a little small, so it seems like, you know, a little kid just coming up to hug. But I'm curious, in how do you try to manage that behavior, especially as she gets older? Do you have any suggestions for how to, you know, indicate to her that it's not appropriate, other than just telling her, no, no, you can't really do that?
That's a great question. It's too bad that we have to have those kinds of concerns, isn't it? But I know that there are going to be some breakout sessions that will probably address that as well.
Well, I think it's important to use the same sort of approach we use with typical kids, and it is tough because, you know, we tell our children not to talk to strangers, and yet when you're in the grocery store and the cashier says, "Hi, what's your name?" and the child looks at them with terror because that's a stranger, and I've been told not to talk to strangers, and yet people are telling you you have to be social and appropriate. It's very confusing. And so I think you really want to use your gut level instincts, that you want to teach her personal safety and not only the social appropriateness of things. You know, as you say, we think it's cute when a child is young that they do these things, but it's not appropriate, and it can be misinterpreted as children get older. So I think, you know, trying to exercise proper cautions and helping her to understand what is appropriate, what's not appropriate, and maybe just sort of using those words. Sometimes it's helpful for kids when you sort of say these are appropriate things and these are things that are not appropriate, and it's not that you're bad or we're mad at you when you do these things that are kind of in the inappropriate category, but, you know, make that sort of association. And it's easy when things are pretty black and white, and then your job as a parent is just to sort of over time help them to understand sort of the subtleties. Maybe another strategy can also be to help to teach her to check in with you, you know, so like, you know, look to me and say, is it okay? And then you can give her that feedback, you know, assuming that she has the impulse control to stop and to check back with you. But that's also an important component too, because a lot of kids with developmental disabilities have trouble with impulse control, and so you can tell them something a million times, and then when they're in the situation, they do something that you're like, wait a minute, we told you not to do that, but it's really because they're having a hard time in the moment. So giving them a little warning, maybe before you're going in a situation, let's think about things, you know, if you're not sure, then ask me, before they get kind of caught up in things. But I know it's easy for me to say, just be patient, it'll get better as they get older, but, you know, it really is, it is a process. But it's important that you start early so that they don't get into situations where it can be dangerous.
Sorry.
As Natacha said, often this kind of behavior is a manifestation of impulsivity. And with that in mind, recognizing that in ADHD, impulsivity is one of the 3 core behaviors: inattention, hyperactivity, and impulsivity. Any variety of those can suggest ADHD. That's not to say all children who have the kind of social pattern that you described have ADHD, but I think it should be looked at because impulsivity is so strong with children with ADHD. Sometimes treating for that will help the impulsivity, and it may help some of those social patterns that you just described.
you had a question, right?
Dr. Mattson, I believe, when you were showing us your presentation, and you had two categories, children that I believe were 2.6 to 17 and 11 months, and then you had the adults starting at 16. Why was that overlap, and what would differentiate the two?
A good catch on your part. It wasn't a typo, but the measures that we use for the adults can be administered to people down to 16, but we would start at 18. So we would, because our child measures go up through the end of 17, and we start at 18 with the adult measures. But there is a window of overlap between the two sets of measures.
Okay, as far as the ADHD is concerned, our issue is our daughter has a severe heart issue. Is there any medications that don't affect the heart as much? And she also has the compulsiveness is pretty bad, and she repeats a lot. Even when you ask her to stop, she'll continue. So I don't know.
Do you want me to answer that from the cardiologist standpoint? So the question is, are the behavioral medicines dangerous if your child has a significant heart defect, like hypoplastic left heart syndrome? So the answer is, in general, they're actually very safe, but we still like to be consulted before our children with heart defects are started on medications. There's maybe a very small subset that could be at risk, but in general, the commonly used medications that people like Dr. Stein prescribe are actually quite safe for children with congenital heart disease.
But you would want to make sure that your pediatrician knew.
Paul said that
Here, Marty.
if you have it, if one of your children are diagnosed with ADHD and your pediatrician or family physician suggests starting a stimulant medication, for example, like Concerta or Adderall, I think all those children with a congenital heart defect should be seen by a cardiologist, ideally a pediatric cardiologist, and run that by them. Do they feel that your particular child would be safe with it? Now, I have probably sent in the last 5 years 15, 20 children in that situation to cardiologists, including Dr. Grossfeld, and they've all approved using the medication. So in general, I think it is felt that it is safe. This all came about just a couple of years ago when someone suggested a correlation between sudden death in children with ADHD treated with stimulants compared to kids with ADHD without stimulants. But actually those studies are very murky, and that relationship has not been well established. But because it's been raised, and because theoretically these medicines for ADHD could affect the heart, particularly heart rhythm, we always get approval from the cardiologist before initiating that therapy. There is one medication you can discuss with your pediatrician that may not have as much effect on the heart, and that's bupropion or Wellbutrin, which can be used for ADHD, but it's not as effective as medicines like Concerta or Adderall.
Do you want to add something, sir?
No, I was just going to echo what he said.
Okay, we're just going to go around, so everybody be patient. We'll get to everybody.
I apologize if this question has already been addressed because I missed part of the ADHD talk this morning. But my curiosity is I have a 14-month-old and she's showing some signs of impulsivity, and I'm just wondering, are there any things that you can suggest to support her, you know, on an early intervention type perspective, or things that we can do that don't include medication? Because my understanding is that you don't even diagnose until about 5, according to the DSM, is that right? Pardon?
All three of you can probably answer this one.
Yeah, let me just take the medication piece, because I think maybe an important part of your question is the behavioral suggestions. But until a few years ago, it was felt that ADHD is a diagnosis beginning in school-age children, starting at about 6. But since then, there have been a number of studies, one particularly good one, looking at a drug like Ritalin or methylphenidate in preschool children with ADHD, 3 to 5 years of age. And these are pretty severe children with ADHD, and the parents all had protracted 12-week parent training before it was started. They still had ADHD. And it did show that the medication was helpful in kids 3 to 6. Now, there are more side effects with it than other, same side effects as older kids, but they occur more frequently. It can be used even in preschool children. I think it takes a clinician, however, to use it. Some pediatricians, but not all, are familiar with this or comfortable with treating preschool kids with ADHD, so I'd be very cautious, but it is a possibility, just to mention. You want to talk about behavior?
One thing to keep in mind is that little kids are very impulsive. So, you know, but I mean, if you feel like your child's impulsivity is, you know, seems to be a bit out of the range of what you might expect for a child that age.
Well, I'm a therapist and an educator.
Okay.
So I feel like maybe I'm observing from a different perspective as well.
So you feel pretty confident that this seems to be a bit.
I'm just seeing a few warning signs.
Yeah.
Some red flags.
Yeah.
Nothing that I would say, oh, clearly. But,
Right.
But you know, as a mom, I look at this from a different perspective. Like, what do I do? It's not like, you know, sitting with a client. It's
Yeah.
very different.
And so young as well. So I think, you know, using what we have some programs at the hospital for young kids, the kids under 2, you know, who are maybe sort of showing in our particular case, red flags for autism, but other kinds of sensory behavioral kinds of issues. And I'm not a therapist, I'm a diagnostician, but my the data that we have so far indicate that, you know, kind of applying those same sorts of strategies in a developmentally appropriate way that you would with a preschooler or a slightly older child seems to be really helpful. So, you know, kind of providing the child with structure, providing sort of understanding what might be some of the triggers that kind of seem to set the child off, or, you know, and helping to kind of anticipate when they're going to have a big meltdown or get themselves into trouble, providing them with the structure that might be more helpful in the long run too. And also, and usually Dr. Stein talks about this, you know, we see a lot of behavioral kinds of sensory regulation issues in many of the kids. Yeah, I mean, it can be. So sometimes when children do things like either to cover their ears for certain things that they find a bit aversive, or maybe sort of they're excited and they're kind of flapping their hands, you know, that might be some sensory regulation kinds of issues. So helping, you know, when you see those sorts of symptoms in your child, trying to help figure out what might be helpful for calming them down. The other thing I was going to say is sleep regulation issues. You know, sometimes when I talk to parents and I ask, like, how's your child's sleep? What about their eating habits? Those sorts of things, kind of keeping an eye on those things. So you know, when a child is feeling uncomfortable or kind of having a hard time regulating their nervous system, then we see a lot of those other kinds of signs. So just trying to, you know, not try to correct everything all at once, but sort of seeing when do things seem to be a little bit better and what seem to be some of the triggers that we might be able to modify. Did you want to add anything?
I'm sorry. Charity, you had a question.
Well, first I want to thank Sarah and Natasha, because honestly, without your guys' diagnosis of autism, our lives were so much different. And through the diagnosis of autism, and because it's a state mandated thing in Indiana that we get services, we receive ABA therapy now. So instead of going through the public school system, which is just horrendous in Lafayette. It has been a nightmare. So thank you, because it's 35 hours a week of Zion being under intense therapy. And it has really changed the structure of our home. It has changed Zion. It has really, really, really helped our family. The second thing is probably going to sound a little harsh, but yeah, because I know he's only 7 and we're the only ones that live with Zion, but I really think that there is a potential of bipolar. I could be wrong, we could be wrong, but his moods are so dramatic from one minute to the next, or even 1 week from the next. I mean, even at school, it's somewhat unlike the autistic children. It's really crazy, but I didn't know if that's a possibility, if that's something that you guys should look at maybe when, or, you know, I don't know, just your thoughts, ideas. I know that people are slow with that diagnosis because it's...
Actually, I'm going to answer that from the genetic standpoint, and then I'll pass it on to the rest of you. Actually, one of the genes right at the end of 11q has been associated with schizophrenia. So it is something we need to be aware of. It's, I think, you know, it's just a very loose association. There's not any confirmation of that, but I think like everything else, you know, 10 years ago, I never would have thought autism was a component of this, and so I think we should be open-minded and consider that and be aware of it.
I'd just like to add that it's comments like that. I know you prefaced it by saying you thought it sounded harsh, but that's how we learn about what to look for. I mean, we have our own ideas, and like Paul said, you know, autism came because people started saying, I think my child has autism. So thank you for that. And that, you know, that's how, but I will also add that we have in our new assessment that we added has a component that will look at depression and bipolar and that sort of condition. So if you're not participating, I'll put in a plug to do our phone and questionnaire. I know you've participated with us before, but in person, but we can also do phone and questionnaire interviews, which will get at those types of questions too, and thank you.
Yeah. I would just add that it's obviously very complicated, and Dr. Stein can talk a little bit more too about bipolar disorder, but I think we don't really understand to what degree it's the same for children with a developmental disorder as it is when we think about bipolar disorder, which is manic depression, which is typically diagnosed in adults who don't have developmental delays and that sort of thing. But we see these kinds of similarities in terms of what you say, like there's these dramatic mood swings. We do see that in a lot of the kids that we see in our center that have autism, you know, and I don't know if there's something different about those particular children, you know, probably from a biological genetic standpoint. I would say that to try to remain hopeful, because the fact that you see these sorts of things and you're very acutely aware of these concerns when your child is young is going to potentially lead to a better outcome rather than, you know, not speaking out about it, trying to figure out how can we help him to stabilize his moods a little bit better, what do we need to do to kind of optimize things as we move forward. And what I tell all parents is that you really want to set up those behavioral contingencies and maybe, you know, medication interventions when the child is young, because they get bigger as they get older, you know, and you want to help him to be able to better control his mood and, you know, how he manifests his behavior when his mood is difficult now when he's younger in moving forward. So thank you for sharing that with us too.
Just a few thoughts. So there's been a lot of controversy about bipolar disease in children. And at the least, it's been overdiagnosed in the last decade. I'm sure it exists, but not to the extent that so many children, and I'm not talking about adolescents, but pre-adolescent children have that diagnosis. I think if there's a family history of bipolar disease, then there's a greater probability that a child might have it. Doesn't say they would, but it's a risk factor. The other thing with the symptoms of bipolar disease, although it's a mood disorder, I think in children it may mimic severe ADHD with aggression. So children with attention deficit hyperactivity disorder, many have oppositional behaviors, as many as 30%, but a subgroup have really more aggressive behaviors, and they can be very difficult, but part of the ADHD. And so treating ADHD with aggression, both from a behavioral point of view and with medication, is one way we go about it. I think that probably exists more frequently than bipolar disease in young children.
Okay, Tim, and then I'll just keep orbiting around. I'll get to you.
I have a parent here from Australia who says it's 4:30 in the morning and she's been up all night watching this. Their son has been hitting himself in the head, staring into space, has repetitive behaviors, gets upset over small things, is very routine orientated and gets upset when there are changes. They're going to see their neurologist on July 16th and want to know if there's anything that they can do to ask about these behaviors and what they should be worried about.
Oh boy, it's an obstacle course. Who wants to take a crack at that one?
They didn't say hello. Okay. I guess I would just encourage the parent to, continue with the neurology appointment, but certainly the potential, it sounds like, for a diagnosis of autism or the types of interventions that might be helpful for children with autism. So seeking out educational and psychological interventions, certainly helpful. Are they listening in? Oh, okay, so you don't have to type? Okay, I'm sorry. So, aren't you typing?
I would agree with what Natacha said. It sounds very much like a child on the autistic spectrum, and behavioral modification techniques may help some of these, but to the degree she's describing it, if it's in the moderate to severe range, I think a medication should be considered. And there is one medication that has been approved by our FDA for the treatment of aggression in particular in children with autism. And it would help some of the behaviors that were described in her child, but not all. And that's risperidone. So risperidone, which actually is in the category of atypical antipsychotic, so it sounds worse than it is, but this is not psychosis or schizophrenia we're treating, but that particular medication can help with a lot of aggressive and externalizing kind of behaviors that were described in that child. And as I say, it has been approved on the basis of a couple of careful scientific studies, randomized controlled trials, in children with autism. Not Jacobson syndrome in particular, but children with autism.
There was, yeah.
So sleep problems is something that's very common in patients with autism, and it's something that can definitely negatively impact behavior. What are your thoughts on the use of melatonin as a sleep aid?
You can't go to sleep, Marty.
Yeah, so there are two basic kind of sleep problems in children with a lot of variations. One is problems with sleep onset or insomnia, and the other is problems with frequent awakening once they're asleep. So you describe your child with really sleep onset problems. Very common. I mean, common in all populations of children. Pardon me?
Probably more with wakening.
With wakening, okay, all right. That's important. It's important to sort out the two, because the medications in particular might be different for the two if you're going that way, and the behavioral approaches probably wouldn't be, well, they would be different too. For the more common sleep onset problem, from a behavior point of view, it's really important to get a very careful history of what goes on at the hour or two before bedtime. What's the pattern of behavior in the family, with the child, with the parents, with the siblings? How is the child put to sleep? Is Frank Zappa on the stereo? Is MTV on in the room? You know, how quiet is the environment, or how chaotic is the environment? And, you know, sometimes we only get that history by really carefully listening. So that's very important. So altering the environment around sleep time can be very helpful with some parents, with some children. Also, you know, if children get up just a little fussy, you know, letting them fuss. Don't just picking them up. Letting them fuss for as much as 5. I generally don't let it go more than 5 minutes, even if they're screaming. Try to let them self-soothe. Try to let them settle themselves. This is particularly, well, this is true for sleep onset as well as night awakening. Now, from the standpoint of medications and melatonin only works for sleep onset. So melatonin is a natural hormone. It's from the pineal gland, kind of in the center of our brain, and it gets excreted at the time of sleep. We have these rhythms called circadian rhythms, and around the usual sleep time, if it's dark in the environment, melatonin gets secreted. Well, the medication just increases your melatonin level, gives you a boost of that. It's to be given 45 minutes before the time the child's supposed to go to sleep. The room should be as dark as possible. And it can be quite effective, not in every child, but quite effective. And I don't know if it's been studied specifically in children with Jacobson syndrome, but it has been studied in both typically developing and atypically developing children, and it's shown effect in both groups. Now, for night awakening, that can be more challenging, but even there's a behavioral approach, and I started to tell you what that is. Maybe my colleagues would like to say more, but you know, so many parents rush and pick up the child, and it's understandable. That's a normal adult human response. But trying to let the child settle himself or herself, if you have to go to the child, not taking her out of bed, patting her, singing a little melody, trying to have her go back to sleep in bed. If there's a lovey or, you know, little transitional object, a blanket, doll, whatever they like, giving them that, using a pacifier for younger ages. There's lots of things you can do to try to help them to go back to sleep in their own bed. That should be the goal. That said, there are some medications that can be used. The one that's used mostly today by pediatricians and pediatric neurologists is probably clonidine. And that can be used safely just before bedtime, and it can help those night awakenings. There are others as well.
Rebecca, okay, and then you follow up, and then I know Rebecca's sitting on a question for a while. So that's fine.
Our daughter was diagnosed with autism, and we got involved in this study out of Children's Hospital in Michigan. She woke up all the time at night, and no offense to the behavioral techniques, but they were not working. And she started on a drug called buspirone, and it immediately affected her sleep. And I know that's, you know, anecdotal, but in talking to the assistants that were working in this research, a lot of the parents were reporting that effect. And the buspirone is really safe drug. She's had absolutely no side effects. Surprisingly, one of the side effects can be that it's bad for their sleep, but it's been a miracle for her. And it started like the first day it started. You know, instead of waking up and, you know, no, she would just wake up confused, not really a nightmare. But she, the first night, she woke up and she said like one word, floor, or something, and then she went right back to sleep. Since then, she sleeps great, and it's also good for, I mean, we've had a lot of success with it, so I like to tell everybody, it's been the biggest difference we've seen in her, and the earlier the better. So once your child is 7 or 8, it doesn't really have an effect. So I don't know how old your child is. 5. You know, just keeping her to do things a little bit longer, giving her like a little bit more motivation, sort of. She's just, and it helps with their eye contact as well. So something to look into. Your neurologist would probably prescribe it. I just wanted to let people know that because we've had so much success with it. Thanks.
You don't work for the company that makes it, do you?
Okay, I actually have like 4 or 5 questions, sorry, just to follow up on some of the stuff in the lectures. But one thing that we're curious about, because we're hearing all the stuff about neurogranin and how it affects memory, and just anecdotally, it seems like so many of these kids have incredible memory on some aspects that it doesn't totally make sense that it would just be that it affected memory across the board, because, you know, I think I was talking to Bethany's mom, and we were just saying, like, watching any of these kids on the iPad is something, like, incredible in the way that they can navigate and memorize different screens, and but that doesn't mean that then Elliot doesn't need repetition in other aspects. So I mean, I'm just curious, as research goes on, if you're going to be able to narrow down exactly what mechanisms neurogranin is in charge of, because it seems like motor planning is a really big challenge for a lot of these kids, and so they wind up with developmental delays in their fine motor skills a lot of the times. But that doesn't, we were talking about how, like, using a normal mouse for a computer might be impossible just because of the pressure and the clicking, but then with these touch screens, it's like, whoa, you can't even believe how fast that they can navigate through it and how quickly they can find different songs, well, in Elliot's case, different songs on an iPod or different movie screens, and get through all of that. And it seems like there's got to be some kind of visual memory skill that a lot of us don't have, who don't have Jacobson's, and I don't know if that's a filter or something. So that was just one kind of question mark, is what kind of memory are we talking about? Because it doesn't really seem like it's memory across the board that's getting affected with them. And then another question that I was having was also about the difference between, and I think you touched on this a little bit when you talked about the different categories for autism and the different things that interact, but I know so many of these kids also have sensory processing issues and are affected by sensory issues, and whether or not that spills into, like, where the borders are of where that spills into autism diagnoses or not, and how much treating the sensory issues might be a pathway as opposed to looking at an overall autism diagnosis. I mean, obviously, if some kids are having an overall autism diagnosis, but I think I've had conversations with Paul in the past about, like, if everybody's missing the same gene, what is it that has some of these kids then going into, like, more of the autism spectrum, and some of these kids just, you know, having repeated sensory processing issues. So that's a question mark. And then the other question mark I had also was when it comes to...
Should I take the microphone away from her?
Please stop me. ADHD. When it comes to ADHD, I remember when Elliot was in the hospital getting his surgery, that a cardiologist said in his experience a lot of kids with heart surgery wind up with ADHD. And I'm kind of curious if, like, the kids who are winding up with ADHD in your studies are also the same kids who had the heart issues, or if it's kids who didn't have the heart issues or having the ADHD, like what the correlation is there. And also if there could be, if that's true, if there could be other causes, if it has to do with the heart surgery itself, if it has to do with the kind of, you know, experience of at an early age being separated from a mother and being put into not having the kind of normal care that you have with skin-to-skin contact, and instead being put in an incubator and being pricked with different tubes and held under different lights and having beeping devices when you're in your most formative time, and if that, and being pumped with all kinds of drugs, if that could have some contributing factors to what some of us are seeing with our kids, because so many of them have gone through some kind of significant medical trauma at an early age, that I wonder if that could be equally contributing as genetic causes of some of these kind of more behavioral issues.
It's coming to get it now.
Can we replay that too?
I'll try to answer a couple of those, but I'm going to need a lot of help from the panel here. So, in terms of ADHD and children with congenital heart disease, I think you've probably covered it in that, to my knowledge, there is a higher frequency of ADHD in children with congenital heart disease, although it's very complex. I think that in my experience, being a parent myself now, it's very natural to overprotect your children when they have significant medical problems, and I think that sort of enables some of these behaviors, so that's kind of one end of the spectrum. On the other side of the spectrum, it's very clear that there are issues with brain development that are associated with heart development as well. So for example, children with hypoplastic left heart syndrome have smaller brains and have less developed brains when they're born compared to non-hypoplastic left heart children. So there's, and as you said, the issues of going on cardiopulmonary bypass can certainly contribute. So there are a lot of different factors. So does that answer that part of the question? Okay.
We have not looked at if the children with ADHD are the same ones that have had heart disease.
So I think my gestalt, although Sarah can back this up with the hard data, is I don't think necessarily in Jacobson syndrome that congenital heart disease is a risk factor necessarily for ADHD, meaning that there are probably just as many kids with ADHD with Jacobson syndrome that have normal hearts. Would you?
You know, we have the information, but we haven't looked at it that precisely, so that would be another thank you for giving us something to look at.
I can say that in terms of cognitive function, I don't think there's any correlation, interestingly, between full-scale IQ and whether or not your child has a heart defect. The question that you asked about neurogranin affecting memory, next time we're going to bring a neurobiologist here. Hopefully we'll have Matthias here, but so forgive my ignorance on this, but there are lots of different types of memory. One of the things I'm fascinated with, as we've talked about, is the role of music. And so I think it's fascinating that I've seen, and I'm sure you guys can bear this out, examples of how children, let's say, that have problems with expressive language, bypass that problem sometimes by turning to music. And I'll never forget when I was at one of the European conferences, there was a piano in the lecture hall, and I just sat down and played a little tune, and all of a sudden 25 kids with Jacobson syndrome came up that were all non-vocal, and they're just singing up a storm. And there's actually, most recently, a biological basis, I believe, for how memory pathways for music are different from, let's say, speech and language pathways. And I'm not going to go into it anymore because I'll totally embarrass myself on my ignorance, but it's fascinating, I think. So the simple question is that, or simple answer, I think, is that there are a lot of different forms of memory. My impression is that neurogranin may be at least initially more involved with short-term memory, but you know, that remains to be seen.
I think I would just add on the memory question that, you know, as you said and as Paul said, that there are lots of different kinds of memory, but there are also lots of different ways of testing memory, and I think it's useful to consider those alternative types of strategies. You know, we're used to certain types of memory tests which may be too challenging for kids with cognitive impairments, but when you think about a different strategy, I actually have a person in my lab who's developing assessments on an iPad precisely for that reason, so that we can look at something more, I don't want to say it's easier, it's just different, right? It's just a different way of assessing. We did try the very first time we were here doing a touchscreen computer test, and the kids still had trouble with it. It's different than an iPad. I mean, I think the limitation was did they understand what what they were supposed to do? It wasn't self-driven, like an iPad, you learn by doing it. You learn to swipe this way, and that, if you press this, certain things will come up. So it was different, but it did take out that, although it does have a motor, you did have to have that motor component that you talked about too. So, but it's definitely something to think about, yeah.
The other thing to add is that with the downside of the cool neurobiological research is that it's mostly done with mice and rats and things, and so I'm just thinking about the Morris water maze task, and that's a motor-based memory, and most memory kinds of tasks that you can do with a mouse are motor, and so it's not to say that motor learning isn't important, but we definitely know that that's different parts of the memory system, and some of the difficulties that children with developmental delays have in terms of motor control and motor memory and motor planning might reflect those kinds of memory deficits that we're finding are linked to these specific neurobiological pathways, but yet the other kinds of, maybe more cognitive, perceptual types of memory skills, which are regulated by different systems in the brain and lots of different genes, may be preserved. And as Sarah and Paul said, some things, certainly kids are fascinating, and probably one large component of the variation we see is that when children might have a similar kind of challenge from a neurobiological standpoint, they find alternative ways, and this is a developing system. So even though we have children here where things are not quite right, there's lots of other systems that are working just fine, and so how your child might compensate, if you will, or figure out how to do things in a different way from other kids, is what we try to encourage. Yeah.
Do you want to talk about the sensory processing?
The relationship between sensory processing and autism.
Where's the line?
So sensory processing, and we certainly see a lot of children in our clinic where sensory processing issues are identified pretty early, and if they also have speech and language delays, and then they have some social issues and restricted interests, then, from my perspective, I might say, well, that kind of sounds like autism. You put those all together, that's what we call autism. Some kids, however, I see where they clearly have much more sensory processing issues, and they have maybe cognitive delays, and I don't think it's autism, but it really takes that kind of clinical view to say, where do we draw the line? These are all also behavioral syndromes, and they're very mushy, and so, like ADHD and autism, like, well, where do you draw the line? Well, children are different, and not everyone fits within these specific boxes, and that's why there can be disagreement, where someone might say that's definitely not autism, and then I might say that definitely is autism with the same child, maybe because it's kind of a bit of a gray zone. And also, another thing to consider is that from a developmental perspective, some things may not be very clear. And so sometimes when I'm not sure, I might make the call, but I'll say, definitely for younger kids, I want to see this child again in a year. If you've gotten some interventions, if certain things have maybe changed, it might be clear, or we might say, no, that diagnosis doesn't seem to fit now.
Did we get them all?
Did we cover it, Rebecca? Okay. Wow.
We can talk to you.
Don't give up over there.
I was interested, like, in the pain tolerance of kids, because LaJoy seems to not feel pain, but in the earlier part, but it seems like it's developing more now. She broke her arms a couple of times or whatever. She just got walked away. Different things that happened to her. It's been really scary, and it's just like she didn't feel anything. This is happening with.
Any of you want to? I think that it begs the question of having a neurologist involved with us to do a comprehensive assessment. I've heard similar stories, but again, this kind of feedback is really helpful to help us to ask the right questions. So I'm hoping we can recruit a pediatric neurologist to do some comprehensive assessments I think there are a lot of interesting sensory processing issues, but this is way out of my domain, so. Okay.
We have a daughter, she's 15 years old. We live in North Wales, and she was diagnosed with Jacobson syndrome when she was 20 months. We've brought her up without knowing what to expect next. My question is that as she's getting older, she's getting more aggressive. We have a younger daughter, she's 10. Then we wouldn't touch her, but now as she's getting older, she started to be more aggressive with her younger sister and towards us. She's like very extreme from one thing to the next. She's very unpredictable. She does things very quickly. We can't even look at her. We can't even speak to her sometimes. Could it be because she's in her teenage years, or would it get better with age? Or, you know, she's showing all the signs of ADHD and autism, but if she's not diagnosed with that, would it get better as she gets older? Or will the behaviour always be aggressive? Because I'm worried in case she hurts somebody.
Have you tried any behavioural techniques?
Okay, sorry.
Have you tried any behavioral techniques to help her handle that aggression, or?
She has a psychologist at home. But
Hang on.
Sorry.
Remember, Australia's listening.
She has a psychologist at home, but nothing seems to be working. We've tried everything. She also gets depressed, she cries, her behaviour is very unpredictable from one extreme to the next. We just don't know what to do and how to handle her.
Well, you've given a lot of information, but I think there's a lot more to learn about your child before I could make a decision on what diagnoses she has, and that's important because that would lead to certain treatments, particularly medication. If aggression is the primary symptom in a child who has autism or doesn't have autism, but if it's aggression, one, I would look to see if there's ADHD present, because that would be the most common behavioral diagnosis, neurobehavioral diagnosis associated with aggression.
Does she have to have hyperactivity with the ADHD?
No. There's one type with hyperactivity and impulsivity. There's another type with primarily inattentive behaviors, meaning difficulty focusing, concentrating, forgetful. That's more the inattentive type of ADHD. But so aggression is often associated with another diagnosis, and you treat that primary diagnosis, and that can help the aggression. For example, with ADHD. Or a conduct disorder. It doesn't sound like she has that. On the other hand, if aggression is isolated, if it's by itself, there are a group of medications that can be helpful. And these are, again, these atypical antipsychotic medications, like the two most popular used are risperidone and Abilify.
Can you get them over in the UK? Because
I'm sure you can.
the doctors won't give her anything.
Right. Well, in the UK system, I think the best person to see a child like this would be a child psychiatrist. It's okay.
Thank you for those insights.
My question is about ABA therapy. I was just wondering whether this is something that's effective for ADHD as well, and if it's effective for children over 5 years old.
So as I said, ABA therapy is really kind of a blanket term for behavioral interventions that are helpful for lots of specific kinds of behaviors, but usually when people say they have an ABA therapist, it's mostly directed towards the sorts of challenges that children with autism have. We certainly use those principles regardless of age, so it doesn't, they may be more available privately for kids under the age of 5, but certainly helpful for kids over the age of 5. I don't know, I think maybe Marty can talk a little bit about the question of ADHD, but usually the kinds of behavioral strategies that we use for kids with ADHD are a little bit different and maybe a little bit more specific for addressing questions of impulsivity, attentional focus, increasing attentional focus, and the hyperactivity, but any good therapist who's kind of worked with kids with autism oftentimes has to address the issues with attention. And certainly for lots of children with autism, if we can't get them to focus and pay attention, then all the hours of intervention in the world are not going to be very useful. So sometimes just having a good therapist who really knows how to kind of get the child to calm down and to focus and then work on whatever it is that you're trying to increase in terms of skills can be very helpful.
I didn't hear the initial question, so.
Oh, she's just saying, can ABA therapy be helpful for kids with ADHD?
Oh, the question is, can ABA therapy be helpful with children with ADHD? Well, yeah, as you heard, ABA, applied behavioral analysis, is kind of an umbrella term for a lot of behavioral techniques. And the therapies that have been studied to be most effective with ADHD are behavioral modification. And this is can be a form of behavioral modification. That's important because other psychotherapies are not particularly helpful with the core symptoms of ADHD. Remember, when we say ADHD, we're talking about hyperactivity, impulsivity, and inattention, or some combination of those. That responds to behavior modification. It doesn't respond to talk therapy, psychotherapy, or play therapy, or cognitive behavioral therapy. However, if you have a child with ADHD and anxiety disorder, the anxiety might well be responsive to cognitive behavioral therapy, but ADHD itself, the behavior therapy is what you want there. Behavior modification therapy. There's a wonderful book, there are a lot of books for parents on ADHD, but there's one by the American Academy of Pediatrics, and it's their only book on ADHD for parents. I can't get the exact title in my mind right now, but it's published by the American Academy of Pediatrics. The editor is Michael Reiff, R-E-I-F-F, and it's something like ADHD, what every parent needs to know or something. And it's for $15, you can get it on Amazon.com very easily. And I require that for all of my new families with ADHD, that their parents read that. And it can be very helpful with behavior modification technique guidance.
I'll get back to you. You're next. You guys are quiet over here.
Mine's just a quick question. Is the term mental retardation a medical term? And if so, is there a specific IQ level that somebody is considered to be mentally retarded? Because I work at a school and everybody in high school, and it's like if you say mentally retarded, everybody is like aghast because it's just considered cognitively impaired. And I wasn't sure. I'm hearing you saying mentally retarded, and I just was not sure.
Who wants to answer that?
So, as politically incorrect as the term is, it is still the medical definition, and in order to meet the current criteria for mental retardation, the child has to have cognitive abilities as well as adaptive behavior abilities that are more than 2 standard deviations below the mean. So an IQ, in other words, that's 70 or below, and some type of adaptive behavior performance like the Vineland scales or another kind of questionnaire the parent completes. That's a standardized type of interview, so that that we basically cover that this isn't purely an educational type of, situation or an environmental deprivation situation, but IQ as well as adaptive behavior. And in the new DSM-5, the proposal is that the term will no but it'll be called intellectual disability. But as far as I know, the definition will be the same as far as I know. So for for many of your children that have very limited abilities and are significantly delayed, that's why we use that term, and not to be offensive in by any means.
You got a list.
Always for you. I have a daughter who's 23 years old. She has the ADHD and does show, signs of the autism as well. She was taking Dexedrine, started on low doses, and she continued on, and doses were increased as needed for 14 years. Most recently, as of last October, she developed a quick onset of high blood pressure. They did an EKG, and she has PVCs. So all the stimulant medications were stopped and everything. So we've been living that way for a while. I've noticed that her anxiety is higher to the has escalated to the point of physical, where I can see red patches coming up her body. Not necessarily like a flush or a blush, but more of a rash-looking development. And as her service dog reacts and we can try and do a distraction mode of some sort, I can actually see the rash go. It was hard to get someone to see it happen, but I finally did. Her doctor did finally see it happen, and that has continued, so her anxiety is obviously up. She's had more problems sleeping, where impulsivity, she'll get up and walk around the house in the middle of the night. The reason why I know is I can hear the dog's bell. The dog will follow her everywhere. So we've noticed it more and more. So her impulsiveness is increased. She's had weight gain, which is difficult because the blood pressure is being controlled by medication right now. The PVCs are still there. We were hoping that the long-term use of Dexedrine was some sort of a cause, but it's been months now, and there's been no change in the situation and no reason why it's there. Echoes were okay. No other significant reason for why all of a sudden she's having, the PVCs. So I'm concerned about, how we control, or if there's a medication that won't aggravate one situation but help the other, because at the same time I'm concerned that anxiety being high, increasing the blood pressure, PVCs being there, I'm kind of walking the thin line. So I just wanted to know if anybody had any recommendations on how to kind of manage a situation like that.
Did you have more? Oh, sorry.
And also, if anybody had an opinion on those kind of electrical video stimulation things to kind of help with that, because of course I'm trying to see if there is no medication option, if there's something else that I can do to try and help control some of her impulsivity, because she will sneak food, and I'll find little bowls of stuff under her bed, on the side, in drawers. And again, she's getting up in the middle of the night and just doing whatever, and during the day as well. And if there are any medications, because she does have the chronic platelet dysfunction, things like the clonidine that you recommended, she does take very limited doses of Ativan because she has Jacksonian seizures. So that's another reason why they have problems finding medications for us. So I need help with those situations. Thank you.
I'll just comment real briefly on the cardiac. So for those of you that don't know, PVCs means premature ventricular contraction, or sort of in layman's term, a skipped beat. They're usually totally benign, actually. I'm obviously not Clea's cardiologist, but knowing that she's had open heart surgery, I would take that seriously, but I wouldn't necessarily deem her as not a candidate for some of the medications, so you just have to be a little more rigorous maybe about evaluating that. I'll pass the rest of it on to my colleagues.
Right, so I would want to know how many of these new behaviors occurred after stopping the amphetamine. You implied that the anxiety and maybe the increase in impulsivity is since stopping the amphetamine, is that correct?
No, she had the diagnosis of ADHD prior to that. We didn't want to try any medications until after 9. So we didn't start anything. We had symptoms up until 9 years old. We started medication from 9 to 23. We had a very good span there until most recent complications. A lot of her symptoms were controlled. Cognitive abilities were increased. She had, made huge strides in school, learning. Participated in like 4 years of high school cheerleading.
And all of that was just with the amphetamine?
All of that was with dextrine only.
Yeah, so you have a real motivation to try to find something that will treat her ADHD, and it may well have been treating her anxiety as well. Remember, I mentioned that about up to 30% of children with ADHD have some degree of anxiety, and when it's mild to moderate, the anxiety actually decreases or even goes away just with the stimulant medication like amphetamine or methylphenidate. So I'd be motivated to try to find something that could substitute for the amphetamine that would be safe for the heart, but that would help her ADHD and anxiety. And it's kind of a challenge. Guanfacine is a medicine that's recently been approved for children with ADHD. This is an old antihypertensive drug, interestingly, that it wasn't antihypertensive when I was in medical school. And it was discovered that in adults they treated with guanfacine. If they were aggressive, their aggression went away or diminished significantly as a side effect. So now it has actually been shown to be helpful for ADHD and particularly ADHD with aggression. Tenix is a brand. Actually, the newer form of it is called Intuiv, I-N-T-I-N-U-V, Intuiv. And there's also a long-acting clonidine that could also be affected. So that's one area. Now, if anxiety is the main symptom, then we usually think of something like an SSRI. Prozac being the prototype, but there's 10 others. Now, those medications generally don't target the ADHD symptoms, but the anxiety you speak of, they do. And this, it's complicated as you describe it, so I would try to get somebody who's really experienced with medications with children, either a developmental behavioral pediatrician or a child psychiatrist, in some cases a child neurologist. It varies.
Well, to add to that, in your opinion, from the cardiology standpoint, since I had such good success with the dexedrine, would it be an option to consider going back on a low dose since it didn't change anything and it wasn't a cause for what's going on?
Yeah, I would absolutely suggest exploring that in conjunction with her cardiologist and her pediatrician. Let me go here and there's, okay, hang on. let her and then we'll go to you and then come back around.
So I have a son, Isaiah, he's 9, who has Jacobson. I have 3 questions. One is similar to the woman that spoke earlier about social awkwardness with children with Jacobson syndrome. In one aspect, my son can be very social. Like, he'll come up to people that he doesn't know. I'll go anywhere and they'll say, "Oh, hi, Isaiah," and I'm like, "How do you know him?" But the question is, do you have any recommendations for how you can encourage social appropriate conversations with peers? So that's why he'll be really socially awkward when he's talking to someone that's his own age, just engaging in a conversation. So that's one question. The second question is, are you seeing any disparities between skill, cognitive abilities between math versus language arts with children with Jacobson syndrome? My son seems to do really, really good with math, but when it comes to language arts and reading long passages, he has difficulties. So one of the teachers were asking me to get him tested for ADHD to see if he may have some attention issues in reading, just giving that attention to reading long passages. And the third question is, I remember reading about Jacobson a while ago, and it seemed to say that children past 3rd grade, they have difficulties going to mainstream schools past 3rd grade specifically, and I was just wondering if there's been any children that have been able to go to mainstream school past the 3rd grade and keep up with mainstream education. Just 3 questions.
Yes. Let's let Erica, and maybe you can introduce yourself again, Erica, because you're the perfect person to answer at least question number 3. Ah, perfect.
For your 3rd question, I'm actually 33, and I just found out when I was 30 that I had Jacobson's after I had my son Kylan. And I actually graduated with an associate's degree from college. So don't be discouraged in any way. You can do it. I mean, they have, at the local college I went to, they had free tutoring. They had everything right there for you. They have a learning center where you can take tests and take all the time in the world. So don't be discouraged at all. They can do it.
Erica was our keynote speaker at the last conference, by the way, and shared her story.
I think I can answer part of your question. You asked about the discrepancy between mathematics and reading, and we haven't been able to look at that in the detail that we would need to be able to answer that question. So I think it's a really interesting idea, something that we need to follow up on, but we haven't been able to look at it. And I think, to echo what Erica's saying, as you asked about mainstream school, I mean, I think the people in this room are the best people that can answer that question for you, in terms of their experiences. They've had so much more experience than any of the 3 of us have with Jacobson, or 4, maybe. So I think, this is a great group to be able to get at that answer for you. And I think you had one more question, and I don't, it was about social. Yeah.
Oh, yeah. So to follow up on the last thing before I forget, one possibility, I haven't seen that particular note about 3rd grade. One possibility is that typically for kids that are doing okay in school, they may have more trouble moving to 4th grade because the challenges increase, so that I don't think that there's some magic piece of data that's out there about Jacobson syndrome in particular. It's just that there are unfortunately a lot of kids who probably needed a little bit of extra help early on that got by, and then once they get into 4th grade, it's assumed that your reading is right on target, and we don't have to worry about those things. And so that might be some of the concerns. Certainly the ADHD is an important thing to consider if you sort of feel like your child is having a hard time staying focused at the level that's required for longer passages that is typical in 3rd and 4th grade. But I would also take a look and see if, and this is easier said than done, but I see a lot of kids like this where they need a good kind of reading assessment. So, he's able to read, but maybe his comprehension isn't quite up to speed, and so having to read something for a longer period of time gets overwhelming, because it's you have to keep track of what you're doing, and kids who are doing okay, then start to avoid things that are hard for them. And so the more you avoid it, the worse it gets, and everyone else keeps working, and you're falling farther and farther behind. So he might need some extra help at school and maybe some tutoring outside of school to keep him on track, you know, and don't be ashamed to kind of say, you know what, he's entitled to some services, and we want to keep him in the mainstream classroom, and we need a little bit of extra support. With the social awkwardness, again, you know, maybe there is a little bit of difficulty regarding ADHD possibilities, but maybe he has, even though he's approaching other people, maybe not always appropriately, he's got the interest, so we want to engage the interest, but we want to also teach him how do you approach people appropriately, and how can you maintain an age-appropriate conversation, and who are the best peers to do that with. And so maybe some help from like a social skills group, or maybe a speech therapy group for kids his age, to kind of have the support of a therapist to work in a sort of safe environment, as well as at school. You know, we oftentimes try to get those services, if we can, in the school, because that's where he spends most of his time. You know, to get him a little bit of help from a counselor or something during lunch or something like that to help build those skills.
I would certainly support trying to find a small social skills group, because with a good therapist working with the kids, that can be very helpful when they're learning social skills in groups with peers. Peers at their level. With regard to the discrepancy between math and language arts, you know, we all have strengths and weaknesses in our learning abilities. The most brilliant people and those with disabilities, we all do. And so some kids, it's more dramatic. So, I mean, getting a more thorough evaluation, if you haven't yet, about his language aptitude and his language achievement would be very helpful in developing a strategy for therapy. But, you know, the simple thing I tell all parents is, in a situation like that, is maximize his math talents. You know, give him lots of math books, get computer programs with math, you know, do math problems at the dinner table. You know, if that's his aptitude, you know, go for it. Do a lot of math stuff, and get a tutor for reading, somebody who's experienced tutor. You know, while you're getting the evaluation, because the tutor will be helped by, will help guide his or her treatment by knowing what the strengths and weaknesses in languages are, and whether it's more receptive or expressive, and or what type of reading problem he really has. Yeah, but I would just go for it and just start if you haven't yet.
Thank you for being so patient.
Our son is 5, and he has autism, ADHD, and Jacobson's. And, you know, he has very intense, strong interests that are very restricted. And for the most part, you know, they've been very socially appropriate. For example, he's into the movie Cars 2, and his whole thinking 24/7 is all about cars paraphernalia. But I am concerned because most recently he's had a less socially acceptable interest, which includes a little boy in his class, which he actually has no relationship with. But in his mind, he feels, you know, this boy is his whole world. And I was wondering, you know, we're doing things like social stories and redirecting, but I am concerned, you know, when he gets older, about the different kind of obsessions he'll have later on, and what kind of things that we can do to help him. And another question I have is, do you endorse or, you know, about the gluten-free, casein-free diet for autism? And have any comments about that?
So with regard to the interests, and you and I talked a little bit about this, I think if he has, does he have like a behavioral therapist that's working with him? So I think for kids that are getting into that age where they're in school, you know, if you can get even some short-term help from a good ABA therapist to work on some of your specific concerns, that can be really helpful, because we do want him to, again, kind of learn what are the social boundaries of, you know, interest in children, and when a child, I've certainly seen kids where they seem to be interested in particular people and it doesn't seem to be, you know, reciprocal, how maybe we can shape that into a behavior that's a little bit more reciprocal, and to help it, you know, not become something that's going to have other kids avoid him because they think, you know, that that's intrusive, or they don't really know how to respond. So working with somebody who can help you in the school as well as outside of school to broaden his interests, I think would be helpful. With regard to the diet, for those of you who don't know, there's been, you know, certainly a movement of parents who have been interested in alternative types of strategies for helping kids with autism and other kinds of behavioral issues. So far as I know, there hasn't been any scientific research to support the gluten-free, casein-free diet in terms of changing behaviors for kids with autism. I've been to many research meetings talking to gastroenterologists, and for children who definitely have food sensitivities or allergies, if, you know, eliminating certain kinds of foods in their diet can improve their behavior a lot, because they're not sick all the time or they're not feeling poorly. So anything that you want to consider in that regard, I definitely would want to talk to a physician about it, and sort of consider what your expectations might be. But in terms of, you know, specific research that suggests that that is warranted for children with autism, it's a really difficult study to do. UC Davis has been trying to do some work in that area, and if there are specific indicators for changing your child's diet because of food allergies or GI problems, then you want to talk to a doctor before you change things, because it's really difficult. You know, it's difficult to eliminate bread and milk from a child's diet, and you sort of need to know what the expectations should be.
Back there. Okay.
Hello. So I'm getting my Ph.D. in neurobiology, and we study circadian rhythms. And so I don't know if you can answer this or not, but if any of the genes that are lost in 11q are related to any circadian rhythm genes, or because my brother sleeps about 12 hours a day, and so he's very active, so that could be part of it, but 12 hours is a lot. So if you can't answer it, then it's just a curious thing we should look into, I think.
What do you want to do for a postdoctoral fellowship? You're hired. The answer is I'm not aware of any, but I'm not aware of any genes involved in circadian rhythm regulation, except for you did hear Dr. Trier's talk this morning about. But yeah, so I think in a nutshell, one of the things he demonstrated is that the BSX gene does seem to have an effect on sleep behavior, or sleeping patterns. So, and there are actually 2 papers now out by a researcher in Moss, M-A-A-S, that you might want to look up, on studies of sleep problems in Jacobson syndrome. So that might be enlightening. And then maybe, you know, we can offline look at the genes that maybe you might have a greater knowledge than I do that might be relevant. I was waiting for you to raise your hand.
Great. Hi, my name is Trisha. I have a son who is 7. He's on the autistic spectrum, and we've been doing therapy since he was 2. I'm wondering if you guys have found any critical age where you have seen more permanent successful outcomes of behavior based on intervention earlier than a specific age. We just started a new program with my son to help him on focus and attention span, and it has to do with we're working on coordination and development with thinking, so he'll have to like say the alphabet forwards and backwards while he's doing coordinated tasks. And it does seem to have, you know, it gets him thinking and challenging. But I'm wondering if there's different ages where you see a critical age of actually having permanent implications for brain improvement on behavior.
Well, that's a much bigger question than you may know, how big that question could be. So I think, but it is a really important question. So not specific to just autism or developmental disorders, but her question was really, you know, are there these critical points? And those of you who, you know, might have studied psychology or biology, there are old studies looking at critical points in development, and there's certainly critical stages where certain things, if you, like, you know, the kitten studies, where if your eyes are closed when you're an infant for a very long period of time, then those parts of the brain that are important for visual, you know, processing will not develop normally. So there's a critical period at sort of basic sensory levels. When it comes to development of cognitive abilities and behavioral abilities, etc., there is enormous change throughout development, and certainly we see major changes in the brain systems that set up shop, that regulate a lot of behavior and cognitive processing in the first 4 or 6 years of life. I'm involved in a large study at UCSD where we're collecting data. We've collected data on now 1,200 children across the country, where we're looking at the differences in how the brain system set up shop from ages 3 to 21. And so there's still a lot that is, you know, remarkable that we don't really know, that we're learning a lot about. But certainly I think that there is something magical about the first 5 years of life. From a biological perspective, we see that there's a huge amount of change. So there's an overproduction of connections between the neurons, and there's a pruning process that takes place in the first 5 years of life at a big rate, a big dramatic change. But that continues on, and there's continued changes in brain connections throughout life. And then you get to be my age and everything sort of falls apart. But in the first 20 years of life, there's a lot of change. And so, you know, I can say from a personal perspective that, you know, I've had to talk to families about, you know, about their child's development, and once you tell them that their child has a neurodevelopmental disorder, they say, well, then I guess that's it. But no, it's not it, because even though there are differences in the child's development, there's still a lot that can go on, and there's still a lot that can change. And so I would say, you know, the long and the short of the answer is that yes, that's why we really promote early intervention, because we know in the typical brain that there's a lot of stuff that's going on, and we want to kind of capture that flexibility or plasticity that people talk about in the first few years of life. But there's still a lot that goes on, you know, past age of 16, past the age of 20. And you have to build that foundation, and then things can continue to grow. So that was your neurobiology lesson. I hope that's helpful.
You couldn't be any further away, could you, Jeremy? It's all right.
The good thing is most of my questions are for you because they're on the I guess the first question is on the neurogranin. You would discuss having multiple genes. Are there multiple genes in neurogranin on the 11q?
There's only one neurogranin gene. What I was getting at is that there are other genes also implicated in contributing to the cognitive dysfunction.
And then kind of going back to what Jenna had asked earlier with the medications for ADHD and all that, with most of them being a stimulant type, how does that not affect the, we already answered the congenital heart, but what about the bleeding disorder?
So as far as behavioral medications that might affect platelet function, I'm not specifically aware of any. Marty, are you? When in doubt, the best source sometimes for these kinds of questions is actually your pharmacist, like at your local children's hospital. They're a wealth of knowledge. And I'll be the first to acknowledge, in my case, they know way more about drugs and drug interactions than most of us physicians do. They've saved me many times, let me tell you.
I think this relates to part of your question. There are drugs that are non-stimulants that can be used for ADHD. The two stimulants are amphetamine and methylphenidate, or Adderall, Concerta. But non-stimulants, one is atomoxetine, which is, the brand name is Strattera, and the other I mentioned before, the guanfacine, or Intuniv, is another one. These are non-stimulants. But I agree with Paul. I'm unaware of any of these drugs affecting platelet dysfunction. But before I would prescribe a child with Jacobson syndrome, I would check that.
Yeah. Okay, we got a couple over here, and then Tim, or is that the poor person in Australia still that's been up all night? Okay, we'll come back. Hi there, sweetheart.
You later, okay? I just have a question regarding my daughter. I'm noticing like a couple of weeks ago, she started, eating or biting her fingers, and she just get like a panic, and she doesn't want to go out of home. And she used to go before with the grandma like all happy, but now she doesn't want to go over there. So now that the doctor said, I think that maybe schizophrenia is related with 11, right? Is that what I heard? That schizophrenia is maybe related with 11?
There's a loose association.
Oh, okay. So the question is because on the family runs schizophrenia, both sides. So what can I do to find out at early age if she has some symptoms or anything? Because sometimes she doesn't want to go to the movie theater. She gets like panic, or sometimes she has anxiety. So what can I do?
My turn.
No.
You can speak soon. Who wants to take on that one?
Yeah, I mean, it sounds like, without knowing your daughter, it sounds like anxiety sorts of issues and behavioral, issues, and we can talk about this. I think you might be coming in for, is she coming in? She was just. Oh, okay. Behavioral types of strategies to address those. I would try not to think about the bigger kinds of questions at this point. I mean, it's not an unusual sort of thing for sometimes children, sometimes they change their mind about what's upsetting them, and you might be seeing her, manifesting that by biting and trying to avoid certain situations. You want to kind of take a behavioral approach to address those concerns.
Okay, so I'm sorry, do I have to make an appointment with my primary care, or do I need to go to the psychologist?
If you have a psychologist that you're working with or a behavior specialist, then I would definitely talk to them about those issues. Yeah.
Tim. Did you still have a question? We'll come back. Okay. Okay, we're down to about the final 3 minutes here.
Okay, I have several questions. The first one is from my wife in Maine. We have a daughter who's 4 years old, and she has complex motor stereotypies. It took us several years to figure out what that was, after ruling out seizures and whatever. When she has these, her whole body will lock up where she can't talk or do anything until that has ended. It only lasts maybe 10 or 15 seconds and can happen many times in an hour. And just want to know if that is related to 11Q at all. And the next question is from Sarah in Dallas. She wants to know what the average deletion is with kids with Jacobson. And she has a 10-month daughter, and wants to know what age should she go and be evaluated by a neuropsychologist.
I can answer the easy part of that question. That is, what's the range of deletion sizes? There are deletion sizes that only affect the very, very tip of 11q, meaning less than a megabase. And there are some that can go up to like 16 megabases. So it becomes sort of a matter of semantics. At what point do you call a big enough deletion Jacobson syndrome? Because clearly the kids that just have a teeny tiny deletion may not even be affected, or there's some evidence suggesting that they are. So it's still sort of a work in progress how we define Jacobson syndrome. You can define it clinically, or you can define it by molecular criteria, or some combination of both, I think. I'm going to pass it on to the rest of the group.
Did you know anything about stereotypies?
I don't even know what that is. So you can enlighten me a little bit.
Well, a comment about the stereotypy that was described. So stereotypies are repetitive, usually motor movements that are frequent, although not required for diagnosis of autism, but are seen in many autistic children and adults. But they can also be seen without autism as well. The classic ones of flapping movement, or hitting like this, or twirling on your toes, banging the table. These are repetitive motor movements known under the name of stereotypies. But the one described there by the parent from Australia, you know, it doesn't sound like a stereotypy to me. I'd have to see it. I would have to see a video of it or see the patient. But as you're describing it, it sounds either like a tonic seizure or something that's not a seizure but more psychological in response. So I think really a neurologist would have to evaluate that. Or perhaps it is a neurologist that decided it was a stereotypy, but as it's described, I was uncertain. There was stereotypy. Yeah, as an isolated behavior, they are certainly difficult to treat, although behavioral work is the way to go. The medicines we used for autism generally do not affect stereotypies, but it's forms of behavioral modification, or ABA therapy, may have some benefits.
There was another question about the age, I think, at which to get an evaluation. Is that right? And the child was 10 months. I mean, I think you can definitely get assessed at any age. We can do more as children get older, but I don't think there's any harm in getting assessed early, so you have some information to go forward with.
I think we're going to have to wrap things up so that you parents can fetch your children from the daycare.
Can I make a little...
Pardon me? And pizza is here.
I need to make just an announcement.
Okay, so first of all, Sarah wants to make an announcement. I want to thank all of you and our panel for taking the time to do this. We've never done this before, but I think this is a wonderful forum. At least for me, it's been extremely educational. I think we'll open up potentially new avenues of research. And again, you guys are what makes this go. So, Sarah, did you want to say something?
Yeah. No, just quickly, if I could see the Thomas family, the Armitage family, and the Bromand family just for 1 minute, that would be great.
So don't forget, pizza is out there. And then we'll reconvene at 2 o'clock with Dr. Martina's talk.